Hi everyone, this is an audio review for quiz number 6, which covers chapters 6, 16, and 14. Okay, so as a review, in chapter 6, fluid and electrolyte and acid-base balance. Remember, we talked about homeostasis and how the body tries to maintain a balanced condition from an internal standpoint, and so it plays a big piece. Regulation is always aimed at maintaining homeostasis. So we have to remember intracellular. Remember, intracellular fluids are fluids inside the cell. And just remember that intracellular fluids actually accounts for most of the fluid that our body carries. Okay, and then we have extracellular. That's all the fluid that's outside of the cell. Just remember that when we talk about extracellular, there's two pieces to this. Intravascular, that's the fluids traveling through our blood vessels. And then you have interstitial fluid, which is just a tissue that's surrounding the cells themselves, and that includes lymph fluid, okay? So remember, extracellular fluid, when we talk about the extra fluid space, it's responsible for carrying nutrients and waste throughout the body. Ideally, it's going to distribute that nutrients to the body and then collect up that waste that's a part of metabolism to eventually be eliminated from the body, usually via the kidneys. Okay. Remember, we have lots of different types of solutes. Sodium, remember sodium level is 135 to 145. It's normal range. It is the most abundant or a large quantity in the extracellular fluid space. So that's in the blood vessels, in the interstitial tissues, okay? And it plays a big role in fluid regulation, muscle activity, nerve conduction, as well as acid-base balance. The other solute or electrolyte we need to really pay attention to is potassium. Remember the normal range is 3.5 to 5.0. Remember, potassium is mainly in the intercellular space. In other words, most of the potassium that our body has is inside those cells, okay? And it plays a big piece in osmolarity. That's we talk about concentration, volume, and the other piece here is that it's important for normal membrane excitability. In other words, it's necessary for nerve impulses, okay? As well as, protein synthesis, breakdown and synthesis of glycogen, as well as plays a piece in acid-base balance. Calcium is another one. So when you think about this one, just remember that it has a reciprocal relationship with phosphorus. Remember, if calcium's high, phosphorus is going to be low. If phosphorus is low or high, calcium's going to be low. They kind of push each other in different directions depending on what's causing the increase in one or the other. Remember, 8 to 10 is considered a normal range for calcium. Okay. Magnesium, remember, that's one of those that plays a role in metabolism of carbohydrates and protein, as well as neurotransmission, particularly in the heart and muscle functions, as well as nerve function. Normal is 1.5 to 2.5. Remember, when we talk about solute, there are a lot of other substances that dissolve in body fluids that are not electrolytes. So your protein, your glucose, your bilirubin, and creatinine are all. Remember, these don't carry a charge. Okay. We talked a lot about transport, the different mechanisms. Let's kind of go through those. So we have diffusion. Remember, diffusion is just a random movement of particles in all directions. And its natural tendency is to move from higher concentration to lower concentration, okay? And this is solute only. In other words, what's in the fluid is what moves, okay? So remember, diffusion is solute only, and it has to do with its concentration, and it moves from a higher concentration to a lower concentration of solutes. Okay? So eventually it will balance out in terms of solutes. Okay? Next one is we talk about active transport. These is a process of where protein carriers help move substances from a lower concentration to a higher concentration. In other words, it has to work against natural movement. Generally speaking, when we talk about natural movement, it's from higher concentration to lower concentration. So it's moving from an area of lower concentration to higher concentration via a protein. Then we have filtration. Now that is all driven by pressures. Remember when we talk about filtration, that has to do with solutes and water. Okay, it's the combination of the two. They move solutes and water based on pressure, and it still works in the same way, from higher pressure to lower pressure, and solutes and water will move in that direction. Next piece is osmosis. Remember, that's only the movement of water, but it's based on the concentration of solutes. So what are the electrolytes? What are all the particles in that fluid, in the water, that derives it, okay? Remember, this is really important that osmosis basically uses osmolality to maintain homeostasis, okay? Remember, osmolality is the amount of particles dissolved in the water, and that sort of gives us a concentration, okay? All right, so remember, osmosis only moves water, but it's based on how much particles are dissolved in the water and has that shift, okay? So basically, think about this. If we want to equalize the concentration and only use water, it's going to shift from lower concentration of solutes to higher concentration of solutes. So basically, it's going to make one compartment more concentrated and the other compartment more diluted until they equal in terms of concentration. Fluid imbalances, we need to kind of talk about that for a little bit. Remember, you have fluid volume deficit. The big thing we often see here, we need to kind of know what there are a couple of ways you can have fluid volume deficit. One is hypovolemia. Most commonly, that would be through bleeding, or the other type is through dehydration. Okay. So it could be, remember these things, it could be related to decreased intake or abnormal fluid loss. Okay. Like, for example, vomiting or diarrhea, or excessive bleeding. So signs and symptoms we need to kind of be looking for when we talk about these. Think about it. Blood pressure. Blood pressure will tend to go up. Heart rate will tend to go down, right? Decreased volume. Other things we will often see is tenting with skin turgor, flat neck veins, because there's not very much fluid in those vessels, and so you're not going to be able to see those neck veins very well. They'll be kind of flat. Okay. And then we need to talk about excess fluid volume. So, that's your fluid volume excess. And, we often see this from like renal failure, your dialysis patient, your heart failure, which would be, congestive heart failure, or it could be related to hormone production. And we'll get more into this, but remember, antidiuretic hormone, aldosterone, those types of things are holding fluid. So if you have a problem in too much secretion of those hormones, it can cause that fluid volume excess. And of course, excess overload on isotonic fluids, and so on. Okay, so then we need to go through the different types of imbalances in terms of electrolytes. Let's start with hyponatremia. That's lower sodium level in the bloodstream than normal. So anything below a 135 could be considered hyponatremic. But we have to remember that there could be two ways this can happen. One is a loss of that sodium. There's not enough sodium. Or there was an increase of body water that's diluting the amount of sodium, so that concentration decreases. So signs and symptoms we often will see with this is headaches, muscle cramps, fatigue. As it progresses and gets more decreased as far as abnormal, we will start, see confusion, orthostatic hypertension, and what have you. So usually the treatment for hyponatremia is usually restriction of fluids, depending on the cause. But the idea is that the restriction of fluids will allow the kidneys a chance to get rid of some of the extra water. Okay, diuretics, so particularly furosemide, is often used. If the hyponatremia is severe enough in terms of its lab value, they may also do sodium replacement therapy. That could be via IV, with concentrated normal saline, like a 3%, 10% normal saline. Or there's actually pills, medication. Samca is an oral medication where it actually helps increase the sodium level while getting rid of water. Okay. So the big thing here is when we talk about hyponatremia, you need to really watch for input and output, okay, and assessing mental status, because these people will get confused and disoriented. The more severe the hyponatremia is, the lower that value is. Hypernatremia, that's the other side of this. So that's anything that anybody with a sodium level of greater than 145. This is a real serious imbalance because it can actually cause death if it's not corrected. For the same reason, it could be related to excess retention of sodium or excess loss of water. Okay. So the big thing here is think about it. If you have lots of sodium, it's going to make them thirsty, dry mucous membranes. They're going to have decreased urine output because of all that sodium. It's kind of, water follows salt. Okay, and they can have convulsions or seizures. Okay. So the big thing here is it's kind of the treatment here is going to be oral or IV replacement of the water component. So to bring it back in balance, essentially what we're doing is we're diluting the sodium, and then we're going to do a low sodium diet. So we need to really make sure with patients that we emphasize what is a low sodium diet. So they should be avoiding processed meats, ready to eat meals, those microwave dinners, those types of things. Canned foods tend to have high in sodium as well. So we kind of need to make sure we teach them what are appropriate foods to eat to maintain a low sodium diet. Okay. So let's talk about the next electrolyte that's really important to know, hypokalemia. So that's your low potassium. And so there's lots of reasons that this may happen. It could be related to gastrointestinal, could be related to kidneys, could be related to all these things can cause problems in these areas, So your GI tract, renal function, cardiac function, and neurologic. Remember we talked about potassium has a big piece in muscular nerve conduction, right? And so that's where it affects the body the most. So when we talk about the big thing we worry about, there's two things. One is abnormal heart rhythms. They can potentially be fatal. Okay, but then the other thing we really look for, especially if we find that somebody seems to have low sodium, we want to assess their respiratory status. Because remember, when somebody has low potassium, they are at risk for weakened muscles. And they may not be taking full breaths to the point where they stop breathing because of muscle weakness. And when we talk about respirations, we're trying to see if they have shallow respiration. And oftentimes it could lead to what we call flaccid paralysis, essentially stop breathing because of all that muscle weakness. Other things we'll often see is anorexia, diarrhea, muscle cramps. We talked about the dysarrhythmias, confusion, and polyuria, excessive urination. Okay. So when we talk about hypokalemia, their treatment is potassium replacement, whether it be intravenous or oral. Okay. These folks are usually going to be put on anybody who has a imbalance in potassium are going to need to be on a cardiac monitoring so we can watch for those dysarrhythmias. Okay. Key thing here with potassium, we want to make sure that urine output is not less than 30 mLs an hour. Okay. And the other piece with this is that you never give more than 10 MEQs of a potassium replacement an hour. Okay. So that's particularly IV. Okay. We have to be really cautious because we can actually cause some fatal arrhythmias just by giving potassium too fast, particularly via the IV route. The oral route usually is not much of a concern. Okay. So let's move on to the other side of the potassium problem. So hyperkalemia. So that's an elevated potassium greater than 5.0. Big thing here is just remember we have several patient groups that are at risk. So anybody who has a decreased renal function. The big one that comes to mind when we talk about that is diabetes patients. Okay. Anybody who is in metabolic acidosis tend to have a higher risk for elevated potassium, as well as anybody taking potassium replacement. If you remember, we talked about potassium replacement with potassium-wasting diuretics, particularly furosemide or the brand name, trade name of Lasix. So oftentimes patients who are receiving furosemide will get potassium replacement automatically with it. We still need to monitor it because sometimes they're maybe getting too much potassium because the diuretic is not really pulling off that much. The effect of the diuretic is not quite that much. Okay? The signs and symptoms we need to kind of look for, big one is explosive diarrhea. If somebody's got hyperkalemia, we often that would be suspicious, especially if somebody starts developing all of a sudden explosive diarrhea. They're going to have those muscle cramps, weakness. They're going to have that kind of parathesis, so that numbness and tingling feeling. They're going to usually be anxious, abdominal cramps, and urine output will be decreased. So the big thing here is when we talk about treatment is the underlying cause. So one of the first steps we'll do is do a potassium restriction diet. So they need to avoid foods that are high in potassium, for example, bananas. Okay, but then the actual medical treatment, remember we talked about there's several ways that they will usually try to bring down that potassium. So one is the K-oxalate, which is an oral or a enema preparation, and that draws potassium out via the GI tract. Just remember, K-oxalate doesn't work right away. It actually takes time. And one of the problems with hyperkalemia is that you can have fatal dysrhythmias or fatal heart rhythms. So oftentimes they want to correct it faster until that K-oxalate works. And that's when they will use IV insulin with 50% dextrose. And what that's doing is, remember, insulin, is designed, to bring in glucose into the body, but it actually brings in potassium as well. So if we give them a IV dose of insulin, it's pulling in that potassium into the intercellular space. So that means it's not free floating around to where it can get to the heart and cause arrhythmias. But we have to worry about the other side of the coin. It does decrease glucose levels. So we always give that 50% dextrose with it so that they won't have hypoglycemia. Okay. Monitor urine output is the big piece. If somebody is taking potassium-sparing diuretics, they're at risk for, the hyperkalemia. So you have to be watching for those medications. We talked about flow of potassium, never more than 10 MEQs an hour if they're getting any replacement, which is oftentimes they get too much replacement. And of course, we're going to monitor those labs. So remember, when we talk about hyperkalemia, we're worried about the irregular heartbeat, okay? that dysarrhythmias. That's kind of one of the big things. Calcium. Let's talk about calcium. Remember, calcium imbalance is regulated by the parathyroid. Okay, so hypocalcemia is kind of the first imbalance when we talk about that one. It'll be often caused by diarrhea, if they have prolonged diarrhea, or a lack of calcium or vitamin D intake, if they're getting multiple blood transfusions, okay? Because the citrate that are used to preserve the blood binds to calcium, and so it ends up actually pulling it out of the body. And then you have some disorders, particularly think about parathyroid, if there's a problem with the parathyroid, under functioning, so we call that parathyroidism, we're going to have that hypokalemia, that low calcium. The other side of the coin, is hyper. Let me back up here. Let's talk about symptoms first of hypokalemia. So low calcium. So you got to remember it's going to be neuromuscular irritation. Okay, so they will feel numbness, tingling in the face, muscle twitching, severe muscle cramps, which usually starts in the hands, feet, and the legs first, and kind of moves to the core. And then we'll have, remember, we talked about 2 really easy ways to kind of assess for low calcium level, and that is the Trousseau sign. Put the blood pressure cuff on, pump up the cuff, you leave it on for a few minutes, and you will start to see carpopedal spasms where the hand is flexing and kind of pointing, kind of. And then you have your chest stick sign, which is because of the neuromuscular irritability, you can tap kind of right in front of the ear. You're tapping the facial nerve, and it causes them to have that twitching, and it's uncontrollable twitching. Okay. Seizures is not uncommon with this, depending on how low the calcium level is. Of course, muscle weakness, and we will see bradycardia with this. In other words, a slow heart rate. So let's go back to the hyperkalemia, high calcium. The causes is kind of the opposite in general when we talk about hyper. So too much calcium or vitamin D intake, a problem with the parathyroid overactivity, so hyperthyroidism. And immobility is one of the reasons that somebody can have elevated calcium level. Think about it. If they're immobile, not doing weight-bearing activity, calcium is going to leave the bones and go into the bloodstream. So when we talk about signs and symptoms for this one, we're often talking about anorexia, nausea and vomiting, abdominal pain, constipation. Okay. They're going to have fatigue, weakness, and muscle pain. Big thing here is they will be disoriented with trouble thinking and have heart palpitations, okay. Kind of heart beating fast. Okay, so let's talk about the various components of electrolyte imbalance. Fluid balance, a fluid balance. So let's start with the kidneys. Remember, they're the main regulators of fluid balance. So, there are several components. One, it serves as a filtration, right? Okay, so that's kind of where it enters the kidneys, goes to glomerulus, the glomerulus filters, and so on. And then you have 2 things that can happen. One is we call tubular reabsorption, the reabsorption of stuff back into the bloodstream, okay, or back into the body's circulation. So ideally what it is, it's going to retain water and solutes, particularly mostly sodium, okay. And remember, this reabsorption is adjusted based on volume, and we'll talk more about that. Remember, there are certain hormones that play a role in that. But remember, if tubular reabsorption goes up, we're going to see more concentrated urine, right? Think about it. More water is being kept in the body, so the urine's going to be more darker yellow, more amber, more concentrated. If tubular reabsorption is decreased, then we're going to see, very clear, very pale urine, diluted urine versus concentrated. So remember, if reabsorption is increased, you're going to have more concentrated urine if reabsorption is decreasing. In other words, it's letting more water go. We're going to see more diluted looking urine. Okay. Let's talk about the hormones. There are several hormones that play a piece in this. Just remember, aldosterone is the main hormone that works on the kidney to say, retain sodium, retain with that you will get water retention. Okay, but aldosterone is not stimulated until renin is released. Okay, so renin is kind of the trigger for aldosterone to be released to tell the kidneys what to do. So remember that this based on two pieces. One, if blood volume. So if blood volume is low or if blood pressure drops, renin is going to be released. With renin, it's going to stimulate the release of aldosterone. And then aldosterone goes to the kidneys and say, you know what? We don't have enough blood volume or blood pressure is too low. I want you to hold the sodium, and by doing that, we're going to retain more water. Okay. Okay. And also, just kind of a sidebar, is that with that, usually more potassium is released into the urine. Okay, so it doesn't reabsorb potassium. The other piece that plays a role in this is your antidiuretic hormone. We call it ADH for short. This also tells the capillaries to reabsorb more water. Okay, and so the same thing happens. It leads to more concentrated urine and less urine being excreted as a result. Okay. Now, remember, we got all these things that are telling the kidneys to keep stuff, keep sodium, keep water. We have a counterbalance to that, and that is that's in the heart. Okay. And that hormone that it's secreted we call atrial natriuretic factor, ANF. And so its response is if there's too much water, it's going to release this hormone. And this hormone is released when the atria of the heart gets stretched too much. And that's like its sensor. If the atria is getting stretched too much, that's when this hormone is going to be released. And basically, it counteracts the action. So it decreases the production of renin, decreases the release of aldosterone, and then it also causes vasodilation, so that fluids can kind of move out. The other piece here is you got to remember, the end result of this is to decrease blood volume and lower blood pressure. So, remember there are two pieces: the kidneys and the heart, or the cardiac system. So remember, these two work together to maintain fluid balance as a team. They're kind of counterbalance each other. Okay? The other thing here, other component is thirst. Remember, thirst, that's a sensation of you feel like you need to drink fluids, and that has to do with increased osmolality. So just remember, more sodium and less water in the body makes the body thirsty. Okay, so your concentration of sodium increases, it will stimulate the thirst. Okay. So we need to talk about fluid gains and losses. You have to remember, as a general rule, healthy adult, the input and the output are going to be approximately equal. And so we just need to keep that in mind. But there are lots of ways that we lose water, and we refer to that to insensible water loss. So that's loss through sweating. It's when somebody sweats, working out, so on. Or another place where this can happen is in the lungs. Okay, we do have a normal amount of where water is evaporated as we exhale. Okay, when we blow out, we're blowing out warm, moist air. Okay, another place we see this is in the GI tract. Okay, there's a certain amount of loss. Okay, in terms of that. So when you have increased respiration, increased sweating, we have an increased risk for insensible water loss. Okay. when we talk about, assessment of fluid light balance, you gotta make sure that you're monitoring input and output, and that includes, bowel movements. When we talk about it, constipation is actually considered an early sign of dehydration. Okay, and so we need to be watching for that. So that includes checking your skin turgor, looking at the mucous membranes, looking for edema if we're concerned about fluid overload. Okay, all those things. When we talk about diagnostic tests, one of the ones that really plays a big piece in terms of we need to be aware of in terms of fluid balance is, hemoglobin and hematocrit. Just remember when we talk about these two labs, these labs will be affected by fluid balance. Okay, so if you have too much fluid, that means there's going to be excess water. So we will see hemoglobin and hematocrit decrease because it's being diluted. And if there's dehydration present, we will see hemoglobin and hematocrit numbers increase. Okay, so what often happens is they look like they have an elevated or a normal hemoglobin and hematocrit, and then we hydrate them. We give them fluids to get them rehydrated, and we'll see a notable drop in the hemoglobin and hematocrit just from the fluids alone. Okay, so we need to be aware that hemoglobin and hematocrit are affected by dehydration and fluid overload. Okay, and we need to know how those affect it. Remember, so dehydration tends to increase hemoglobin and hematocrit, and fluid overload tends to decrease it because we're diluting the blood. Okay. Make sure you know your EBGs, how to calculate your EBGs. We went through that in class. But let's go through some of the specific acid-base imbalances, the different types. Remember, we have respiratory acidosis. So that is an increase in the carbon dioxide into the body, and so as a result, your pH drops. Okay, so we often see this in a number of things: pneumonia, drug overdose. Think about anything that can suppress the respiratory system and being able to exhale and blow out excess CO2, and then it builds up. Okay, so that's respiratory acidosis. Usually we try to improve ventilation. It's often what we try to do to correct this. Okay. All right. Respiratory alkalosis. So remember, this is a lower than normal carbon dioxide, and which leads to an increased pH. The most common thing we usually see this in is hyperventilation, like somebody who's breathing really fast because they're having a panic attack. Okay. So oftentimes, we need to reassure them. Oftentimes it's related to anxiety. We may have to administer anti-anxiety meds as ordered by the physician. Metabolic acidosis. So this is bicarb now when we talk about metabolic. Okay, so remember, metabolic is bicarb, and there's not enough bicarb, decrease in bicarb, which actually leads to a decrease in the pH. Okay. So we often see metabolic acidosis in diabetics, so diabetic ketoacidosis, renal failure, dehydration, okay, starvation is other things. So oftentimes we will see altered mental status, altered level of consciousness, vomiting, diarrhea, and then you will see arrhythmias related to it. The big thing here is correcting the imbalance in itself. What is causing that metabolic acidosis? And that's where it's aimed at fixing. Okay. Metabolic alkalosis. So that's excess bicarbs, and which causes the pH to go up. Things that cause this is excessive vomiting. Remember, we talked about mouth being alkalosis. Okay. Diuretics, other electrolyte disturbances can actually cause metabolic alkalosis. Okay. And so the treatment mainly depends on the underlying causes. Okay. So that's chapter 6. Let's go to chapter 16. That's fluid intravenous therapies. Okay. So remember we talked about the different types of IV fluid: isotonic, hypertonic, hypotonic. So remember, isotonic is similar to the same concentration as the body. So examples of, remember what happens if we give isotonic fluids to a patient? There's not going to be a shift, right? It's equal to the body concentration, so there's no shift in fluids. Think of osmosis, okay? So examples of isotonic is normal saline or 0.9% normal saline, lactated ringers. Okay, those are considered isotonic. Hypertonic solutions, remember this is the fluids is more concentrated, more solutes compared to the body. And so remember what happens, body fluid shifts out of the cell into the circulation, into the vascular space. Okay, so we would often use this for like edema, okay, to try to get some of that excess fluid out of the tissue. So examples of this would be 3% normal saline, 5% normal saline, 10% dextrose with normal saline. You know, anything that's kind of above the 0.9% is considered hyper. So anything above that isotonic. So hypotonic solutions, these are fluids that have less concentration than the body. And so remember, this will shift water into the tissue, into the cells. Okay. And so, you know, we would use this for like dehydration, where it's most commonly used. And so, you know, half normal saline or 0.45% normal saline. Those are kind of the same thing, just to do it differently. Or 0.225 normal saline or 1/4 saline are considered hypotonic. Okay. Components of IV fluids, we have to remember, the components, the concentration is important, but we have to remember that there are lots of things that can be in the fluids depending on what it is, or the fluid selection. So water, dextrose, sodium chloride, and other electrolytes, okay? Just remember that when we talk about if there's any additional electrolytes, you never give anything with potassium as an IV push. Okay? It always has to be a slow infusion. Remember, no more than 10 MEQs an hour. Remember when we talk about dextrose is actually the only source of calories in IV fluids. Okay, so think about total parental nutrition. That's the intravenous nutrition. That's very specific. Remember that usually has a combination of lots of factors, lots of things. So it's got the dextrose, very high concentration. It's going to have protein. It's going to have vitamins, minerals, and electrolytes. Okay, and then lipids is a separate piece. For a separate infusion. Okay. So let's talk about intravenous access, particularly catheters. Remember we talked about, a catheter is usually it's like a plastic tube over a needle until it's inserted into the vein, and then we leave the catheter in. But remember, there are lots of different sizes. So we need to remember that we refer to that size as a gauge. So the larger the diameter of the catheter, the tubing, it's the tube itself, the smaller the gauge. Okay. And then the smaller the diameter of that tube is, the higher number gauge. So just to give you a reference point, a 12 gauge is way larger than a 22 or 24 gauge. Okay. So most often, the one that's used most commonly is like an 18 to 20 gauge is usually safe for most uses. But remember, we always want to pick the most appropriate one for the purpose. Remember, when we have anything infusing, we always have to reassess every hour. That's making sure that it's infusing at the appropriate rate, as well as looking for any signs and symptoms that might indicate any complications, and we'll talk more about that in a minute, okay? But every hour you should at least going in and assess it, making sure it's infusing at the correct rate and for any complications. Okay, lots of complications we'll talk more about in a moment. Let's move on to like when you're starting IV therapy. Remember, we need the appropriate equipment. We need to make sure we pick the correct, most appropriate site. We talked about that. It's always going to be, you should always use the non-dominant arm, and you always start distally. And as IVs need to get changed because they go bad or get old, you work proximally up the arm, okay? Let's talk about all the different types of complications. So the first one, is infiltration. That is fluids going into the tissue instead of into the vein. So we call that infiltration. Usually, oftentimes a patient may report that there's pain or it's burning sensation in the area. But when you go to look at it, it will be pale, puffy, kind of like edematous, and it oftentimes will feel cool because of that cool fluid in the tissue, and hard because it's kind of got a lot of fluid buildup. Okay, so how do we address this? We obviously stop the IV, discontinue that IV access, start a new one, going up above. Okay, we elevate the arm to kind of help promote that excess fluid return to the body to be reabsorbed, okay, and elevated on a pillow. Okay. But remember, signs are pain or burning sensation. It's pale, puffy, cool to touch, and also kind of hard to touch. Okay. The next complication is inflammation, phlebitis. Kind of goes together. They're kind of the same thing. Remember, phlebitis is inflammation of the vein. So remember, this is more of irritated. Okay, veins are irritated. So redness, swelling, warmth. It'll often be tender at the site. Okay. If it's severe enough, we may see purulent drainage with that. Okay. So that's the second complication related to intravenous therapy. Third one is fluid overload, fluid volume excess. So we need to be watching for those things. Big thing here, is we need to be watching for rising blood pressure, bounding pulses, edema. Remember, if it's enough fluid buildup, we will often see pulmonary edema and congestive heart failure. Okay. We also might see distended neck veins or jugular vein distension in relationship to that excess fluid buildup. So what do we do with this? Slow down the rate. I'm sorry, let me add to this. They're often going to complain of dyspnea, kind of fluid buildup in that lung. That's that pulmonary edema. So with fluid volume excess, we need to slow down the infusion rate, elevate the head of the bed for the patient so that we can optimize air exchange by minimizing the amount of surface area being covered with the excess fluid in the lungs, and notify the physician. And he will often he'll give you orders to address that issue. The next problem is decreased cardiac output, and that's pretty much related to bleeding, whether the tubing gets connected from the IV access in the arm, or if bleeding when we discontinue the IV access and we don't apply enough pressure. So the key thing here is applying enough pressure, making sure all your tubes and all your connectors are really tight and secure. If there is a large amount of blood loss, need to assess vital signs because they may start showing signs of hypovolemia, low blood volume, and then you need to call the physician, okay? Impaired circulation, that's basically embolized, so clots. So remember we talked about there are 3 different types of clots we worry about. So one is actually the blood clot, okay? And we're worried about it getting into causing obstruction. So, big piece here could be in the leg. We might get a DVT, but we worry more about an embolus getting to the lungs, and we call that a pulmonary embolism. Okay. So that's one piece of it. So we will often see they will complain of chest pain, sudden onset of chest pain, dyspnea, shortness of breath, restlessness because of respiratory distress. Okay. And also we will often see hypotension as well, blood pressure dropping in relationship to the blood clot in the lung, a pulmonary embolism. Air embolism is also another concern. We see this more with central lines because of its large bore catheters going directly to the heart. So we always want to make sure we avoid accidentally introducing air into those accesses. And that's pretty much chapter 16. So chapter 14, incontinence. So incontinence, need to know your diagnostic tests. We talked about clean catch urinalysis, how that's done, what are our options if the patient is not able to comply or follow instructions. We may have to get a straight cath. Another diagnostic test that may be ordered is post-void residual, or we call it PVR for short. And what we're doing here is we want to measure how much urine is remaining in the bladder immediately after a patient has voided. Okay. So we need to make sure when we're doing this, we instruct the patient to call us as soon as they finish voiding so that we can measure. Remember, there are 2 ways to do this. One we could do, which is non-invasive, and that's using a bladder scan, which is like an ultrasound device, and it estimates the amount of urine that's remaining in the bladder. Or we can do actual, like, straight cath, and we measure that urine that's still in the bladder. Okay. Remember, normal urinary amount of urine to be retained is 50 and less. Okay. As a general rule, anything over that is considered inadequate emptying, but even more specifically, a major concern if it gets greater than 200, then there's obviously some major inability to empty the bladder. Okay. Other tests we worry about, imaging. We talked a little bit about that, looking at structural defects. But urodynamic testing, remember that is assessing the neuromuscular function of the lower urinary tract. Okay, that's kind of one type of test. Then you have your uroflowmetry. This is, remember, it's 3 pieces. You pee into a funnel, and it's called a flow meter funnel, and it's measuring how long they void, time-wise, how much they void, and how fast are they voiding. In other words, how many mLs are you voiding in a minute. Okay. Then you have your cystoflowmetry, and that is actually assessing the neuromuscular function of the bladder. Okay, and that's kind of the main function with that one. Okay. And then we have that provocative stress testing, which is usually done in a doctor's office. It's actually very simple. They're looking at stress incontinence. They will basically ask the patient, either they'll do it standing or in the lithotripsy position, and the physician will instruct the patient to relax and then cough really vigorously, really deeply. And what the physician is trying to see is, with that coughing, did they accidentally lose some urine, lost a little bit of control of urine, okay, with the coughing. Okay. Cystoscopy, that's, looking at the bladder and the urethra. It's like a scope with a camera. They're going to go through the urethra, look at the urethra and the bladder,
and to see if they can detect any abnormalities. Okay, so let's talk about therapeutic measures, particularly for urine incontinence. So bladder training, remember there are 3 pieces. We need to educate them. It's then doing the actual scheduled toileting, that's the big piece, and then positive reinforcements when they're able to do it. So when we do bladder training, we're taking them on schedule every 2 to 3 hours while they're awake. Habit training is a little different. And then when we talk about bladder training, remember, we are telling them to resist the urge to urinate until the scheduled time. That's ideally. So we're trying to get them onto this very specific schedule. Bladder training is a little different, where the aim is to kind of tailor it toward the person's natural or usual pattern. We'll start off scheduled, and then we adjust it based on when the patient goes. So this particular habit training is we do not instruct them to hold it or resist the need to urinate. If they feel the urge, we go to the bathroom, and then we kind of work it from there. Remember, we talk about pelvic muscle rehabilitation, so that's to kind of strengthen the pelvic floor. Kegel exercises are kind of the main thing with this. Biofeedback, which is the electric stimulators, can do this as well. And then for women, vaginal weights may be considered an option. Okay. Remember, we talked about a bunch of different types of urine collection devices. So, you've got your usual indwelling urinary catheters that stay in the bladder. We talked about those external types of urinary collection devices. So for men, a condom cap. Key thing here is we need to educate them how to appropriately apply it. We tell, not the way they tape it is really important. Not to encircle it, because we can cut the circulation off to the penis. And so what we need to teach them is to use an elastic type of tape and wrap it in a spiral fashion. So we're connecting it, trying to secure it without actually strangulating or cutting off the circulation. Remember, we also talked about the female external catheter, and that's the brand name for that one, the one that's most commonly known is the Purowick. But remember, that's kind of placed kind of over the groin area, and then it's applied to a suction. Okay? And the suction is what kind of pulls out the urine as the person eliminates. Let's talk intermittent self-catheterization. Remember, while we do this as healthcare professionals, we do it as a aseptic technique. But when we send a patient home and they're going to have to do their own intermittent self-catheterization, we teach them clean technique. Okay. Remember, we always start off with every 4 hours to do that intermittent catheter, and based on how much they drain, they adjust the time, the frequency. So if there's more than 500 mLs of urine, that means they need to shorten that frequency to do it more frequent. So instead of 4 hours, that might be every 3 hours. Okay. And if it's less than 200 mLs, then we do it the other way. We would say, you know what, instead of going 4 hours, you can do it every 6. So you kind of time it. Remember, we talked about penile clamps. That's to kind of help temporarily control passage of urine in men. Big thing here is it actually compresses the urethra and prevents the passage of urine. But the issue here is that we're concerned about impaired circulation from the device and development of pressure sores. So if a patient has this, they need to remove it frequently and reposition it frequently, okay, to avoid any of those complications. Remember, for women, we talked about pelvic organ support devices, particularly the pessary. That's inserted into the vagina to kind of hold up those pelvic organs, which often helps helps improve the incontinence by giving more strength to those pelvic structures. It is a donut-shaped type of device, and basically it is placed in the doctor's office, and then it needs to be reevaluated basically within 24 hours. So 24 hours later, they need to be looked at again to make sure that it's in proper placement, and patients need to be taught to remove it periodically for cleaning, okay? And often they'll have to do replacement periodically. Know your different types of incontinence. So stress incontinence, remember, is a loss of urine related to anything that causes increase in abdominal pressure. So coughing, laughing, sneezing, lifting. Okay. These are all things that can cause stress incontinence. So remember, the big thing here for treating stress incontinence is a behavior training. So that's the toilet training program, doing pelvic muscle exercises, the Kegels. Also maintaining adequate fluid intake. And for women who are postmenopausal, often topical or oral estrogen will help. The other type of incontinence is urge incontinence, and that's a loss of urine shortly after they have a really strong sense or urge to urinate. Okay, usually it's very quick, within a few seconds. Oh, I feel it. Oh, and then you have an accident. It's associated with a lot of different things. So caffeine products, so coffee and tea, tobacco products, urinary tract infections, dehydration, and so on. So a big thing here is we want to correct the cause. So if it's dehydration, we're often going to do fluid hydration, avoiding caffeine, if that's the trigger, smoking cessation. If it's a urinary tract infection, antibiotics, of course. The other piece we didn't talk about, but one of the causes of urge incontinence might be bowel impaction. So disimpaction would be indicated. Along with this would be behavioral techniques, the bladder training or programs, schedule time to go to the bathroom. Okay. Overflow incontinence, remember has to do with the inability of the bladder to empty for some reason, and so then it ends up, as a result of over distension of the bladder, ends up losing urine, involuntary loss of urine. There could be a lot of factors to this. Big one for men is, enlarged prostate, or BPH, benign prostatic hypertrophy, or hyperplasia. Okay. Or in some cases, it might be neurologic. They can't feel the fullness sensation in the bladder to know that they need to void. Okay. So it all depends on the cause. Oftentimes they will do intermittent or indwelling catheter. Okay, is often done, but it all really depends on the cause. When we talk about general interventions for incontinence, urinary incontinence, we need to make sure we teach them to kind of go to the bathroom on a regular basis. So avoid before and after meals and at bedtime. They still need to drink water. We don't want them not to drink water, because then if they decrease their fluid intake, they are often going at risk for having urinary tract infection and kidney stones. Okay, so we still need to instruct them to drink water. Okay, have them practice urge suppression. We talked a little bit about that. Relaxing, stop what you're doing, clench, and then slowly go to the bathroom. Avoiding caffeine will help with a lot of these conditions. And then avoiding constipation by maintaining regular bowel patterns. Remember when we talked about the risk for urinary tract infection and kidney stones. Remember the amount of fluid we usually recommend is 1,500 to 3,000 mLs of fluid intake a day. Okay? You need to be careful with skin breakdown, because urine and feces can be very irritating and actually can cause loss of natural oils in the skin, which can promote further skin breakdown. So we need to teach them. Change their wet clothes and linens immediately after the incontinence. Wash with mild soap and water. Not anything that's harsh or drying or irritating to the skin. Okay, no astringents or strong soaps. Okay, and then of course you want to be assessing the skin every time you clean the patient. Okay. last little topic is talking about bowel incontinence. Remember, this is not that common in terms of incidence compared to urinary incontinence, but oftentimes it's related to a couple of things. So usually it's related to some sort of anal surgery, childbirth trauma, Crohn's disease, and then diabetic neuropathy. Those are kind of the main things. Sometimes it might be temporary to relate it to severe diarrhea, but just be aware of that. But when we talk about interventions, depending on the cause, remember impaction. Somebody who has impaction can still have diarrhea. It's the heart stool and diarrhea is working around it. So we need to remember, how can we adjust the consistency of stool, which often helps control bowels and kind of develop a more healthy bowel pattern. Okay, so depending on the cause. So think about foods we would give that would kind of thicken up stool. Bread, potatoes, yogurt, those types of things. Okay, that concludes the review. Let me know if you have any questions.